The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanik, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Good morning, everyone. I'm Tony Urbanik, and Naomi Engelman is with us this morning, and we're here with our second edition of our podcast, which is entitled TMD Demystified. And we'll carry on with the topic that we started last time, and welcome you for any visitors that are viewing. The topic I want to carry forward today about this really centers around the concept of inflammation. I mentioned the last video that the whole understanding of TMD revolves around the understanding of inflammation and what inflammation does within the temporomandibular joint and what inflammation does exterior to the temporomandibular joint. So there's a triad, 3 parts to what I found out about TMD, and that the triad is involved with 3 things that are necessary to understand what's happening within the joint and how it gets there. So the first part of the triad is this, and this is learned in dental school. I think just about every dental school teaches you this. I'd be surprised if they don't. I was taught this in the early 70s at Indiana University, and that is how much load of the temporomandibular joint comes from the posterior teeth. And the answer is roughly 90% of the loads on the temporomandibular joint come from the posterior teeth. So you understand that the anterior teeth don't load the temporomandibular joint much, and the posterior teeth do. The second part about my understanding and how this all came to play out is this, and that's something that I didn't rely on the textbooks. I relied on my personal experience as an oral and maxillofacial surgeon over a period of 30 plus years. This was 10 years ago. 30 plus years of actually doing surgery on the temporomandibular joint. And whether I was doing open joint surgery, meaning making an incision in front of the ear and going into the joint and doing some mechanical, surgical, whatever within the joint, or whether it was through an arthroscope, each and every time I did surgery, and they were roughly a couple thousand surgeries, half through the scope and half open joint surgeries, I would take out a piece of tissue and send it to the pathologist. Standard operating procedure for a surgeon to, if you take something out, or even if you want to see what's going on, you take a piece of tissue and you send it to pathology. Literally 100% of the time when that pathology report came back, whether I took out the meniscus or I just clipped off a piece of some tissue through the scope, 100% of the time, the first line on the pathology report had something the pathologist had something to say about inflammation, chronic inflammation, inflammation present, but there was always a notation on the pathology report that there was chronic inflammation within the joint on that piece of tissue, 100% of the time. So from that, I deduced that if you had temporomandibular joint problems, there was inflammation in the joint. And then the second part of the triad was this, and that is how inflammation that we know is there 100% of the time, inflammation within the temporomandibular joint creates all these disparate symptoms. And I'll go through the litany again. Frequent and recurring headache, earache, jaw pain, neck pain, ringing in the ears, tinnitus, feeling of fullness in the ears, subjective hearing problems, dizziness, vertigo, shoulder pain, arm, hand, finger tingling and numbness, and locking. That's the litany, and they're well accepted. Nobody wants to argue with those. except the arm, hand, finger tingling and numbness, which I kind of figured out independently. I don't think that's in the literature quite yet. But here's what it dawned on me after I got doing some thought experiments about this, after I found out how successful the device was. And that is this, and I didn't learn it out of the textbooks. Again, it was, as the proper word is, heuristic, Heuristic, heuristic information, trial and error. But I realized that something I learned from my orthopedic colleagues on my orthopedic rotation in my residency was actually in play here. And the orthopedic surgeons know all about this. They, and the dentists don't. So orthopedic surgeons know all about, in the vernacular, what they call joint splinting, having to do, in their case, the best example is tennis elbow. When you have an inflamed elbow, tennis elbow, the signal of that inflammation goes up the autonomic system to the central nervous system, and the central nervous system registers that there's inflammation within that joint. And the central nervous system says, hey, I'm going to give you a hand about this. Don't move that joint, and sends out another autonomic signal to the muscles, upper arm and lower arm, that move the joint, and says, tighten up. And the orthopedic surgeons know all about this because they talked about it years and years ago when I was a resident. And the pain from a tennis elbow does not come from the elbow itself. It comes from where the muscles are attached to the bone. And if some of you may remember about how where the painful stimuli began, it is where the muscles are attached to the bone. The nociceptors are in the periosteum, and where the muscles are attached to the bone is where the nociceptors are then stimulated when the muscle tightens up and pulls on the periosteum, and it hurts. Now, if you disbelieve that or don't know about that already, that is why when you do your local anesthesia into the mouth, especially when you do a block, mandibular block, when you go through the mucosa, patient doesn't respond. They won't pull back. But when that needle tip goes through and hits the medial aspect of the ramus of the mandible, just at one point, that's when they're going to respond and pull back. That's because that's where the nociceptors are on the periosteum. So this mechanism that the orthopedic surgeons have known forever, they call joint splinting, doesn't have anything to do with the temporomandibular joint. It has to do with all the other joints in the body. Well, that mechanism works for the temporomandibular joint. It's exactly where it works. This joint is just a joint like any other joint. And it's not so special that, like you learned in dental school, everybody talked about how special this joint was. No, it's not really special. It has different anatomical design to it, but it's a joint, just like any other joint. So when you include that understanding of that mechanism that the orthopedic surgeons know all about, called joint splinting, you then can, if you know your anatomy, your gross anatomy, then you can understand what happens with all these symptoms. And it's quite simple. When the joint becomes inflamed because of the three primary causes, which are bruxism, functional malocclusion, and trauma. All three of those cause either acute or chronic inflammation and chronic pain, acute or chronic trauma. So the inflammation then ends up within the temporomandibular joint, and the inflammation then sends a signal to the central nervous system. Central nervous system says, tighten up. And then all the muscles of mastication, of which I won't go through these, we can go through them later on. That'll probably be another edition of our presentations. But the patients will complain right there. They'll come in, doc, it hurts right there. Insertion of the temporalis muscle, or right here, the masseter, or right here, the mylohyoid, and it skips around from one side to the other, and they'll come in one day and they say it hurts here and the next hurts here. And if they're talking to their PCP, the doctor looks at them, their eyes roll back. Or the dentist, you look at it, it's like, I have no idea what's going on here. I'm a dentist, I'm not a physician. It's like, this is unusual facial pain. Everybody kind of clamps it in that category, unusual facial pain. It's not unusual. It's like the muscles at various times under various circumstances are getting signals to tighten up, and then it hurts where the muscles pull on the bone and they have headaches, extreme headaches that go on for 10, 20, 30 years, or jaw pain. And then the second most common symptom of actually behind headache is neck pain. And when this inflammation goes on for a length of time, whether it be several months or several years or several decades, eventually that signal keeps going up to the central nervous system saying, hey, I'm inflamed. I'm inflamed here. And central nervous system says, hey, buddy, I told you don't move the jaw. Now what I want you to do is hold the whole head still. Hold the hip, hold it still. And the muscles of the neck will tighten up, and the patients will come in and they go, doc, it hurts right there every morning, right where the well, they don't say sternocleidomastoid. They say right there, doc, every morning it hurts right there. Or the trapezius across the back, or here. And they will have neck pain. Now, the interesting thing that occurred actually many years ago, as I started to see hundreds and thousands of patients with this problem, is after a while, the inflammation continues. It's not treated for one reason or another, not diagnosed for one reason or another. And the signal goes, hey, I'm still inflamed. The central nervous system says, hey, I told you don't move the jaw. Now I told you don't move the whole head. Now what I want you to do is hold the whole shoulder girdle tight. Hold it all tight. And now the patients will complain of upper arm and shoulder pain. And because of what we call the strap muscles on the side of the neck, the scalene muscles in particular, they're strap muscles. They look like this on the side of the neck. And if you remember from your gross anatomy, because that was my, in dental school, that was one of my high points, learning gross anatomy. And through the scalene muscles come the brachial plexus. And when those muscles get the signal to tighten up, they tighten up and they squeeze the brachial plexus. And as you probably remember, the brachial plexus supplies sensation to the entire arm, hand, and fingers. And that is when the patients will come in and they will complain of arm, hand, finger tingling and numbness. And that's the mechanism of how inflammation within that joint that is untreated and uncared for will cause all these disparate symptoms. Now, ringing, fullness, dizziness, that's a topic for absolutely a total separate presentation of our series. But I won't keep you in suspense. That inflammation can get into the inner ear, and I can show you anatomically where. By the way, I don't know whether I mentioned it in the earlier part of the series, but when I finished dental school, I also finished with a master's degree in anatomy and cell biology. So by the time I finished my 4 years of dental school, I had a DDS and an MS in anatomy cell biology. So I do know a little bit about it, and I was able to use that information when I actually did my own research, trying to figure out why surgery wasn't the answer and why night guards weren't the answer and orthodontic treatment isn't the answer and a lot of things, drugs aren't the answer and Botox is not the answer, which we'll go into at great length later on. But I just wanted to get this across as clearly as I could and distinctly as I could at the early stages of this series to, quote, demystify temporomandibular joint problems. And then we'll talk at great length, I'm certain, about how the device that we developed works and why it works. But it's simple. It unloads the temporomandibular joint. If you had a bad knee, the orthopedic surgeon, if you didn't have anything else to do and didn't want to go into some surgical event, the first thing you do is put you on crutches. Why? To take the load off the knee. And if you take the load off the knee, the inflammation goes away and it feels better. So that's how we started out, and talking with patients. They gave me the key as to, how to treat this thing. If I put my finger, my tongue, my pencil eraser between my front teeth, it feels better. And made a device that did that and unloaded the posterior teeth. 90% of the loads come from the posterior teeth on the temporomandibular joint, and that causes inflammation. And now you know how inflammation can cause the disparate symptoms. So Naomi's with us today. I asked her to sit with us today, and I wanted her to come into this from the point of view as Naomi. Part of her job with the company is to go out and visit doctors in Middle Tennessee, whether they be general dentists, PCPs, ENTs, walk-in clinics, physician's assistants, nurse practitioners, physical therapists, but visit these offices and these doctors and explain to them what we know about temporomandibular joint and what we know about how to treat it non-surgically with the device and protocol that we developed. And so I thought I'd ask Naomi to give us a little insight on what the questions that these doctors have when she explains to them how the device works, which I just explained to you, and how to use it, and whatever other questions she has when she goes out. So I thought I'd just ask Naomi. So when you make these visits to these doctors' offices and you're standing in front of a set of doctors and their staff, what kind of questions do they ask, and what kind of doctors are you talking to, Naomi?
Well, as you already know, when you ask this question, I meet with a large array or type of doctors. It's not just one type. And each one specifically has a different direction they go with their questions. And with someone with a background in education, that's my job to kind of prompt them and to dig further and ask questions. And then, sometimes they'll look at me and just kind of stare at me like a deer in the headlights. Like, some of them, of course, will be skeptical. I find that physical therapists, one of their number one questions and ways that they react to it is they immediately want to fall back to dry needling and ask me questions about that and see if that may have a synergist effect with the therapy that you do with the Urbanek device, as well as with dry needling. I think the number one thing that I see is it's such a simple way to approach TMJ that you talk about, that we talk about here on the podcast, that a lot of times you see them overthinking and they think this couldn't be it. This couldn't be such a simple solution. And so I kind of see that link between whether it be ear, nose, and throat doctor, general dentist, physical therapist, chiropractor. I see that whole link, and you're sitting there thinking, you can see it on their face. They're thinking, okay, but what else? A lot of them have treated patients, specifically general dentists, which I've worked with for years. They would try night guards. They would try all type of different devices to try to help these patients. And I think so many times everybody's overthinking the solution that they sit there and look at you like, there's no way this works. There's no way. So that's stuff that I deal with and questions that I deal with. Specifically for audiologists and ENT doctors, my number one question is about tinnitus, which you've talked about. They want to know how the device really helps tinnitus, because that's one of the hardest symptoms, as you've talked about, to get to go away. And so I get questions about tinnitus. I get questions about migraines from your walk-in clinics, which, we've talked about this before. A lot of times migraines are undiagnosed or misdiagnosed with migraines. So a lot of the times when I go out and meet with these nurse practitioners or dentists or physicians, I go into the links or the similar symptoms, if you will, of migraines and how they look similar to TMJ symptoms, and how it would be easily misdiagnosed. So, those are the number one things that we discuss. And of course, general dentists want to know about bite. I tell them that the Urbanek device is worn for 2 months, 24 hours a day, with the exception of when the patient eats. And their number one question, and I can already see it coming on their face, I already know, they're going to want to know, is there super eruption? Does this disturb the bite? So, these are some of the most common questions that I see on a daily basis when I'm out there.
Yeah, I think those are all expected questions. I mean, I get the same questions myself when I'm talking to a doctor. Of course, Naomi is doing the yeoman's work out there, every day, every week. I mean, because of her work, we've have over I think I mentioned this, over 600 referral sources in Middle Tennessee, and their questions are those questions and many more. And I'm happy to answer them. I mean, go down the litany, and each one of these, I think, deserves a whole, 20 minutes of time to discuss. But number one, 24 hours a day, 7 days a week for 2 months does not cause super eruption in posterior teeth in an adult. Now, we can talk about adolescents and children. That is not true for adolescents and children, and I've treated many adolescents and children, and you have to be so-called careful. But mom always goes for the treatment because Sally is crying all night long, and if she understands that it's possible that you have to bring an orthodontist into this later on, if we have problems with super eruption of the posterior teeth, because you know how fast teeth move. The ENT doctors, their eyes roll back in the head when they think that there may be a solution to tinnitus. And again, that's a whole discussion. But when the inflammation gets inside the inner ear, where the vestibular mechanism is and the hearing mechanism is, it will stimulate tinnitus and subjective hearing problems and vertigo. The physical therapists and their dry needling, I have a lot of things to say about dry needling, but the main one is what I see out there is a constant barrage of practitioners, theoreticists trying to treat this problem by actually just treating the symptoms and not the cause. And when you understand the cause is inflammation within the joint, and if you can make the inflammation in the joint go away, then you don't have to treat the symptoms just go away. You're treating the inflammation. So nonsteroidals work great for 2 or 3 weeks, and then they just tear up your stomach if you take longer than that. But inflammation is, handled nicely with aspirin and Motrin and Tylenol for a short period of time, but not a long period of time. And the other point I make about dry needling is I had the unfortunate, and that's the other thing. We're going to talk a lot about the symptomatic relief and the recommendations for treatments that do treat symptoms. I mean, if you paralyze someone's facial muscles, the muscles are not going to pull on the bone, and you're not going to have pain from that particular muscle. On the other hand, it's only going to treat that localized area wherever the ENT doctor or the neurologist or now the general dentist, everybody's getting on the Botox wagon, and you're paralyzing all the muscles, and you're just treating the symptoms. But the inflammation continues within the joint, and it doesn't treat any of the other symptoms like tinnitus or neck pain or shoulder pain or arm pain or finger tingling and numbness. Doesn't treat it at all. Doesn't help at all. So you get the idea that, treating the symptoms with dry needling, which is effective. It has an effect on the muscles itself of the shoulder and the neck, and it relaxes those muscles so they don't tighten up. But again, that doesn't have any effect on any of the other symptoms, headache or tinnitus or whatever. But I had the unfortunate experience to actually talk to a patient who had dry needling, and actually the physical therapist stuck the needle too deep and into the lung, and the patient had a lung collapse and ended up in the hospital because she couldn't breathe. And then they had to do surgery and do, it was serious. Yeah, just because she was having some dry needling because she had temporomandibular joint problems, which were misdiagnosed, just not understood. So look, it's my purpose to demystify, to get understanding. If you don't want to do this, you're not interested, that's fine. That's great. But I need my colleagues, my dental colleagues especially, but also the physicians, because I'm also a physician, they're one of my colleagues, and the physical therapist and the ENT doctors, and especially the nurse practitioners and the physician's assistants that are now manning the walk-in clinics, which now see 70% of the patients who have immediate concerns, immediate problems. They don't go to their PCP, they go to walk-in clinics. So we are doing this to create understanding out there for my colleagues, my medical colleagues, my dental colleagues, because it isn't a complicated thing when you understand it. And if you can make the inflammation go away within the temporomandibular joint, however you can. If somebody can figure out a better way to do it, go for it. If you can figure out a way to long-term make the inflammation within the temporomandibular joint go away, I want to hear about it. I'm all for you. But so far, we determined that if you take the load off the joint long enough, the symptoms will go away. And if you use it then after the first 2 months, 24/7, and then go to nighttime only, in most cases, that's all you need to do. What we found, that 15% of the patients need to use it more during the day, but never 24/7 again. So they figure out, and they come in and they tell me, Dr. Urbanek, I figured out to put this in my mouth when I'm in traffic. And when I'm sitting on the computer, I put it in my mouth. And I don't have any more shoulder pain. And I don't have any more ear pain. And I don't have any more headaches. So that's what we want to just wrap it up for today. With that said, and we will think about what we're going to talk about in our next episode. I certainly appreciate your attention. I would really enjoy and want your feedback and your questions, because we want to answer questions. We've answered a couple of them today that Naomi hears frequently, that I hear, that I know about all the time. But I want to hear your questions. So you can contact Naomi at tmjservices.net. You're welcome to shoot me an email at tony@tmjservices.net. But Naomi has kind of taken a lot of load off me, and I'm trying to develop as many doctors throughout, especially dentists throughout the United States, who use our device and use our protocol to solve this problem and to demystify it for the professions and to demystify it for patients. If you think the doctors are confused, you can't imagine how the patients are confused. I see it all the time after successfully treating well over 3,000 patients. I don't know how many consults I've done. It's like thousands. So I'd like to wrap it up today. Thank you for your attention. Questions, shoot them to Naomi and I. You can find out more about what we do here at www.tmjservices.net. And I look forward to talking with you again.